Welcome to the Healthcare Intelligence Podcast, Stacey. Today we have Stacey Malakoff. She is the Board Director, Advisor, and Audit Chair in the healthcare space. She also has 35 years of leadership experience at the Hospital for Special Surgery. She is the former Chief Finance and Administrative Officer, and she's also a CPA and qualified financial expert in the space. Welcome to the pod, Stacey.
Thanks, Charlene. Thank you for having me. I'm excited to discuss revenue cycle. Not a lot of people are excited to discuss revenue cycle, but I'm excited to discuss revenue cycle.
I'm sure folks are excited to hear from you. And I want to just get started with the first question. What makes revenue cycle such a central part of your leadership? You don't delegate that, and you're very on top of it.
That's why revenue cannot be viewed as one department. At the end of the process, every step affects the next step. My rule was very simple. Pay us what we deserve. Not a penny more and not a penny less. If we got rid of that friction between the hospitals and the payers, costs would be reduced on both sides, and I think we would lower the cost of healthcare. That friction causes a lot of underpayments. So to me, revenue cycle is the connection point between the patient, the physician, operations, finance, and of course the payer.
How do you get physicians aligned? I mean, it's a cycle where every stakeholder is involved, but some physicians like to do more operations than documentation, as you know. How do you do that without making them feel like a billing clerk?
All right, so start one. I would definitely not call a physician a billing clerk, and I wouldn't call a billing clerk a billing clerk. They do a very important function along the whole process. I think physician alignment starts with partnership, not blame. Physicians have to be focused on clinical care. That's their job. And our job is to help connect their care to the documentation and authorization needed to support it. They need to understand, though, where revenue cycle breaks down and how it affects their patient, their practice, and the organization. The best way to do that is with data. Physicians understand data, not antidotes, not finger pointing. Show the patterns. Is one procedure getting denied? Is one payer creating friction? Are we missing documentation up front that causes delays later? And by the way, when you sit and do this with physicians, they understand it even better than the administrator who's doing the coding and the billing. When they see the contract, and they understand it, they will tell you, you need to put this in a contract, or the payer's doing it wrong. We have to go back to the payer and make them understand sometimes what happens in the procedure. So it's really dialogue that helps it become better conversations. Once the physician sees the data, as I said, the conversation changes. Okay? They want to help fix it. They give you the ideas. They give you information that they understand. And as rev cycles, we're not as clinical as them, or not. I'm not clinical at all, but some of the billing people do have some clinical backgrounds. Sometimes we have to ask them for more clarity around the plan procedure or more specific documentation. But the goal is to reduce the denials, reduce the rework, and make sure the clinical work is paid correctly. That's all we want, is to get paid correctly. And a lot of times,
Nothing more, nothing less.
yeah, exactly. And make them feel you're not policing them, that they're part of your team, working with you and protecting the work they did. And their patient, because both times you're protecting both.
And I think one thing that stood out to me is HSS obviously is a specialty environment, a very high volume, high dollar specialty. So it's a little different from other systems who do a little bit of everything, the academic setting. So how does that change the way you approach rev cycle, and how does that affect the way rev cycle engine is being built?
So in a specialty environment, revenue cycle has to be built with depth, not just process. And it does have an advantage. The advantage is that you can hire or train people to really understand one clinical area. They gain deep knowledge, and we're able to work with the physicians and their offices at a much higher level. They're not just processing the claim, they help prevent problems before they become denials. They can say, the payer usually requires physical therapy first, or this payer is going to want medical necessity tied clearly to that procedure. That kind of specialty knowledge creates better pattern recognition. And you can see which payers, procedures, site of care, or documentation gaps are creating friction, and then solve the root cause instead of just working the denial after the fact. Because when you work the denial after the fact, you don't always get paid. And by the way, AI is going to change this. Specialty hospitals' advantages will go away, not fully, but a lot of it. AI is going to become very important. Specialty hospitals have the advantage today because of the deep knowledge, but AI will help close that gap. AI will help surface payer rules, chart details, authorization requirements, and denial patterns much faster than we could in the past. We always had to do things very manual. So the organizations that combine and are able to combine specialty expertise with the AI will be the ones that really improve performance. The goal is the same: deep knowledge, close physician partnerships, and solving issues before the claim goes out the door.
There's quite a few landscape shifting. AI is obviously one. Also, there's regulation that require payers to publish data. Now transparency is out there. Rates are transparent to the extent. There's more volume to ASC. The site of care is shifting. I'm curious, like how, as CFO, how would you navigate this landscape? The site of care shift, the payer reimbursement shift. I'm sure there's other things that you're seeing changing on a daily basis.
Okay, so we'll start with the site of care shift. We'll go to the payer after. Remind me.
Okay.
So the site of care shift changes the CFO's playbook because it changes the economics of the care. From a hospital perspective, hospitals have to absorb shorter length of stay and same-day procedures. That means patient expectations have to be set much earlier. Often in the physician offices, the patient cannot be surprised the day of surgery now that they're going to go home. You know, they speak to their friends, and their friend might have had the same surgery 3 years ago, and that friend might have stayed 1 or 2 days, and today you're going home. And they come in with the expectation of the benchmark of their friend, and that expectation has to be set up front because reimbursements are lowering because people have to go home the same day. Payers are paying for shorter length of stays. 1 day home, it's an ambulatory surgery, not an inpatient. And if the patient stays, you're absorbing the care of an inpatient but not getting paid it. So that's an important shift. Also, another shift is more cases are moving to ASCs. You see price sensitivity and often lower reimbursement in ASCs. Okay? But in many ASCs, the key is physicians have ownership. So the alignment model also changes. Hospital has to make sure that they're not left only with the highest risk, low margin cases. If the mix shifts too far, it becomes very hard to fund the broader mission. And the physicians have to be in it with you to understand the broader mission. So both sides should be able to be happy in the end. And then there's the real asset question. As ambulatory volume grows, full service hospitals have to ask, what happens to the operating rooms, the beds, and the space that the surgeons used to fill? Backfill is not just an operational issue. It's a strategic and financial issue. So the CFOs have to be involved in those discussions and those talks. So the CFO has to understand the economics by site of care, protect the case mix, align with the physicians. Physicians have to understand because they're the main gatekeeper of where the patient goes. Reset patient expectations and make sure the cost structure keeps pace where the care is moving.
With ambulatory volume growing, like how does that change the economics of a surgical business?
ASC growth has fundamentally changed the economics of the surgical business. As I just noted, cases are done in the hospital are increasingly moving to the lower cost, more efficient setting. That creates price pressure, reimbursement pressure, and a real strategic question for hospitals. How do we participate in the shift rather than simply lose the volume? So that is why joint ventures have become so important. Surgeons can open up their own ASCs, and surgeons want to own a piece of their destiny, especially as professional reimbursements continue to be pressured downward. Ownership gives them a way to participate in the economics of the facility and not just the professional fee. But to the positive, ownership changes behavior in a very positive way. When physicians are partners, they focus on efficiency, turnover time, supply standardization, staffing, and case flow. You stop buying 5 versions of the same thing. The team starts asking, how do we do this better, faster, and more consistently? The other benefit is the learnings can come back to the hospital. So ASCs force discipline around cost structure and throughput, and hospitals can apply those lessons to keep their own surgical platform healthier. So ASC growth is not just about moving cases. It's about redesigning the economic model around alignment, efficiency, and the right side of care.
And obviously, physician with more ownership, there is the higher compensation we are seeing. Payer pays less. Hospital has joint venture benefits. But what are the catches? I'm sure there's a few things that about ASC that people don't talk about enough.
The ASC model has a lot of benefits, but there are catches that do not get talked about. You're right. The first is case selection. If an ASC is not talking about case selection, it's the quality game. Quality is the entire game. You need the right surgeons doing the right cases in the right setting. If you move a complex case into an ASC that really belongs in the hospital, you risk a transfer, a complication, or a poor patient experience. And then the model breaks down. Patient history and case selection are non-negotiable. The second is operational discipline. ASCs look simple because they're smaller and lower cost, but they still require very strong management. They are still highly regulated. You need to have the right staffing models, the right anesthesia coverage. You have to have supply chain discipline, scheduling precision, the quality, which is the key we talked about earlier. And there's a lot of compliance issues. Revenue cycle, which we talked about earlier, still has to be clean, and clear transfer protocols. What happens when you actually have to transfer that patient? So the patient has a full understanding of what's going on. If any of these pieces are weak, the ASC can lose its efficiencies, its advantage very quickly. I always say, when you have one happy patient, that gets you 10 referrals. Do the right cases at the ASC and you refer and have a very high quality, and your referrals will continue to come. And then there's one other question, a real asset question. And we talked about this before. What do the full service hospitals have to ask themselves? What happens to the operating rooms, the beds, and the space the surgeons used to fill? And that's where a strategic and financial issue with operations has to come together, which we talked about in the last answer. All of that, so there's 2 sides to it, the efficient and quality ASC and what the hospital has to do to make sure that their mission also stays together. And then the joint venture that comes together and the right management. And the upside is real. ASCs can be more convenient for patients, more efficient for surgeons, and closer to where people live and work. But they are not automatically simple. The right governance, the right case selection, and the right infrastructure. I just can't emphasize it enough.
When you were talking about management, I know you also are a board member, work with many PE-backed platforms. If you were working with like CFO, CEOs on where to start in rev cycle, where would you point them?
Revenue cycle is your capital strategy. Without a strong revenue cycle, you don't have cash. And without cash, you don't have options. It's very simple. Cash is king. It's the same thing. Cash is everything. So I'd start with the back-end metrics because they tell you whether the whole system is working. What are the denial rates? Cash collections, days in AR, daily cash from AR, underpayments, and aging. Those are the numbers a CFO or the operations, everyone should be looking at. I used to get a daily cash report.
Wow.
I knew that if cash was coming in lower than a certain amount throughout a month, then our AR is going to be increasing, and we'd start talking about it. And then once you understand those metrics, I'd work backwards. Are we coding timely? Are claims going out quickly? Are authorizations correct? Are we coding accurately? Are we getting the maximum of our revenue? Remember, I said, pay us what we deserve, not a penny more, not a penny less. Don't upcode, don't undercode. Where are denials coming from? Is it a payer issue, a documentation issue, a coding issue, or an operational issue? But the one advantage that people running it today have is AI. AI is going to make revenue cycle easier, and it's going to continue to make it easier over time. But only if the data is clean and the systems talk to each other. AI can help identify denial patterns. They can pull the data quicker. They can get the key facts to the chart, support appeals, and show where the process is breaking down much faster than we were actually able to do manually. But AI, and the key is, everyone must remember, AI is going to be good, but it's not going to replace leadership judgment. It gives you better information and faster, which should allow you to collect your more cash and get the cash in the door quicker. The mistake, though, is looking for one magic fix. Revenue cycle is beginning to end. From the minute the patient calls to make that appointment till the cash comes in the door, it's everything in the middle. And a break anywhere on the chain can affect the whole result. So my advice to a CFO would be start with the cash, follow the data backwards, use technology to see patterns faster because you'll be able to fix it faster, and treat revenue cycle as an enterprise discipline.
One thing other CFO told us is it's not about EBITDA, it's about cash flow.
It's cash flow. Everything is cash. You need the cash to keep operations going.
Well, Stacey, thank you so much for joining us today. This is wonderful, and we'll send this around our CFO friends and also the team. I think rev cycle is often the most important piece, but least understood of the business. Like surgery is straightforward, physicians do it complicated, but they do it all day long. But to see an organization who has run rev cycle to such a highly efficient model that you have done is really impressive.
So thank you. It really is, and I can't emphasize it. It has to be a joint partnership with the operations, the physicians, and everybody who touches the patient beginning to end. And you are just the person who needs to help administer through it and educate people along the process.
Awesome.
And again, AI is going to change it.
Yeah. It will make it less mundane workflow and just something for provider to fight back what payer is doing on the other side.
That is correct.
Well, Stacey, thank you so much.
Charlene, it's been a pleasure as always, and look forward to speaking to you again soon.
Likewise.